Medical tyranny is universal. I mean, some countries don't even, it's illegal to birth at home. It's illegal to have a midwife in some European countries and in some Asian countries. So
Wow.
yeah, it's an amazing thing that again, it's sort of, it gets to the idea of wanting to control every aspect of your life. And we've seen that in what's going on in the political world that we
Yeah.
have right now. But it's been going on in the medical world for hundreds of years. There's a beautiful cocktail that goes on between mother and baby from the moment it's conceived, a hormonal cocktail. And when you give a woman an epidural, she's now numb. She's no longer communicating with her baby, and the baby doesn't really know what's going on. And you see this deterioration in the fetal heart rate, and nobody really knows what it means, but they always intervene upon it. And often we'll do a C-section, and they'll get a baby that comes out screaming, and it's great. And they'll say, see, we saved your baby. But the truth is that your whole process caused the baby to be troubled in the first place. And if you would just left her alone, she probably would have done fine, as statistics do show.
Any liberty-loving American can see what's happened to the medical industrial complex and how it still threatens medical freedom. And this begins right from the moment of conception. Here to speak on this subject is Dr. Stuart J. Fishbein. He's a community-based practicing obstetrician and an associate of the American College of Obstetrics and Gynecology, published author of many books, peer-reviewed papers, particularly advocating for more of an acceptance of vaginal breech birth. You can follow him on Instagram at Birthing Instincts and his podcast, Birthing Instincts, with midwife Bliss Young. He's offering hope, reassurance, safe, honest, evidence-supported choices for those women who understand pregnancy is a normal bodily function, not to be feared. So please welcome Dr. Stuart Fishbein. Thank you so much for coming on with us today.
Thank you, Christy. I'm sort of honored to be on with you and your list of esteemed guests like Robert Kennedy Jr. and Carrie Lake and Robert Malone. To be on the same set with them is really kind of fun for me. So thanks. I don't get this opportunity very often to talk to a different crowd.
Well, I mean, I can tell you it's, of course, been an honor to talk to presidential candidates and then Ron Paul. Like, I've spoken to actors, but like, I'm really, really, honestly, so thrilled to have you on the show. I have really enjoyed the podcasts I've listened to. I wish I would have found out about you earlier. Obviously, it's become personal to me, being that I'm, like I said before we came on today, of advanced maternal age and pregnant, as the medical establishment loves reminding me of how old I am carrying a baby. So this is a real treat for me, but it's going to be amazing, I think, information for a lot of women that I think are, and I'm hoping are going to be more open to this kind of information now that they see the lies that were peddled during this pandemic we all went through. But I want to like first start with your background, of course, and ask you, because what my first impression was like, wow, like why are OBs, because there's midwives and then there's OBs. Why are OBs like you so rare?
Well, it starts out the way doctors are trained and the way the system has sort of corrupted nature's design over the last century. 100 years ago, 99% of women gave birth at home. And by 1950, 99% gave birth in the hospital, and birth was medicalized. I'm not sure of the motive of the original people that did that. I don't know if the doctors thought they were doing good or if it was just sort of economic tyranny that we see it all going throughout medicine and pharmaceutical companies and things like that these days. But for whatever reason, they took something that was a very natural thing that all mammals do, and they forgot what it's like to be a mammal and how mammals give birth. And if you want to get to the basics of the problems, you have to understand that the medical model no longer considers the human female to be a mammal, because everything they do from the moment that you conceive to the moment you get in your car to drive to the hospital in labor till the moment you put your baby in the car seat to drive home, pretty much everything that's done to you is antithetical to nature's design. And most of it is not for the benefit of the pregnant woman. It's for the benefit of the institution. I'll just leave it at that. We see that mammals, when they give birth, they go off to a quiet place. They go off by themselves. They don't if they're hungry, they eat. If they're thirsty, they drink. They don't want to be bothered. If they're interrupted in labor, if a predator approaches, if there's a forest fire, if little kids run in the room, the mammal puts out adrenaline. Adrenaline stops the labor. The mammal gets up and runs away. And only when it feels safe does the right hormonal milieu and cocktail develop to start labor again. In this way, nature ensures the best chance of survival. So we have lost track of that. We, as a medicalized society, think that we can control everything. And in doing so, we actually cause all kinds of chaos. But the medical model doesn't care about the chaos they cause. What they don't like is the uncertainty of mammalian birth. And so it's not taught anymore. It's not taught in residency programs. Everything is taught about that a pregnant woman is a disaster waiting to happen. And that's how doctors are taught. And the counter to that is the midwifery model of care, where midwives accept the fact that there is some uncertainty. They understand that nature's design, and they believe that pregnancy is a normal function of a woman's body. And if you leave it alone, most of the time, it's going to go fine. And when you intervene upon it, or when you shed fear all the time, then what happens is you create an environment where problems are more likely to happen. And that's where we've come right now. We've gone from a C-section rate 50 years ago of 5% to a C-section rate of over 30% in our country, and over 70% in some other countries like Armenia and South Africa and Brazil. I mean, that's crazy to think that 7 out of every 10 women can't deliver their baby as nature intended, and that more than a third of women need to be induced, that we can't wait for labor to come spontaneously. And, if the outcomes, Christy, were really good, and if we had great numbers and we had a decreased rate of cerebral palsy or neonatal death, then you could say, oh, okay, there's a trade-off, and so you're intervening. But our numbers are no better, if not slightly worse than they were 50 years ago. And yet we have all these interventions that are leading to problems for babies, problems for mothers' future babies. And I don't know what you want to get into, so I'll just leave it at that, and you can take it from there.
Yeah, well, we'll just see what we have time for, because there's just so many different directions you can take it. But what you just said is, I mean, there's so many things that are antithetical to being just plain old logical. And we as women have just been like, oh, well, this is the way that it is, and we've accepted it. Many women, anyways, not me, of course, because I'm the counter narrative kind of a person. But it starts with, what's funny, it starts with this illogical measure of women laying down to give birth to start with. You see all over the world, like tribes and everything, they never like lay down. I mean, that's so ridiculous when you think of it. But I laughed out loud when I heard this brought up in a podcast with you. They're like, oh, that King Louis, he was a pervert. He's the one that started all these women laying down because he liked to watch all his wives and his mistresses give birth, and he wanted that like great angle, if you will. So he laid down, and because people wanted to be like royalty, they followed suit, and that's why we've been laying down ever since. It sounds so ridiculous, but this is the origin story. But I loved the response that you had, where you said, was he a pervert, or was he just a progressive man that like kind of wanted to see how this worked out?
Yeah.
So I thought that was a hilarious response, and one that we could build upon about, what caused you as a man to have an interest in being an advocate for women, and not being sucked in to just, well, this is the way that it is. You being counter to the narrative of medicine, and kind of being a warrior in this area.
Well, I'd have to initially thank my parents for making me a curious lad and always asking why. I was that annoying kid that would say, why and why and why. And eventually my parents would answer with the classic line of, because I said so. And because I said so never sat well with me when I was a kid, and it's never sat well with me now. So I have a way of looking at things that challenges stupidity. And like I respect law. I just don't respect stupid law. And what happened is I, not to get long-winded into my origin story, But I went to medical school at the University of Minnesota, and I did my residency at Cedars-Sinai Medical Center in Los Angeles. And I was very lucky in that time because this was the early 80s, and medicine was different back then. We did things like breaches and twins, and we weren't that concerned, and we had lower C-section rates. And I trained at a hospital where I got to spend 4 months at LA County USC Hospital, which at that point was the busiest hospital in the country. They were doing about 22,000 births a year, which is about 65 babies a day at that hospital back in the early 80s. And so we got to see a lot of stuff. And so I got well trained, but it didn't really affect me initially when I came out. I was the guy that came out in practice and thought I knew everything because, Cedars-Sinai is a good program, and I was a chief resident, and I felt like, I got a great job offer, and I went into private practice. And I was doing everything then that I laugh at now. Like, I was dressed in a full hazmat suit to catch a baby. The woman was up in stirrups with her legs covered with blue drapes, and we'd wash off her bottom with betadine, which is an iodine solution, as if birth is supposed to be a sterile procedure, which obviously it's not. But again, that gets back to the mammalian thing and the microbiome, maybe a topic for later. And then the baby would come out. I would immediately clamp the cord. I wouldn't let the baby get its blood back and have delayed cord clamping and all the advantages of that. And then I would show the mother this wonderful thing that she had just produced. And then I'd walk it over to the other side of the room and set it down in the warmer. And I did this for, probably 5 or 10 years. But what happened, I was lucky because I was approached by some local midwives early in my practice and asked to take their home birth transports. And I said yes, not because I thought midwifery was smart or home birth was smart. I probably didn't know anything about it, but I said yes because I was just looking to make money. It's how it was a different world back then. You didn't come out and get a job working for a big HMO or, some corporate entity. You came out and you hung up your shingle and you hustled to build a practice. And I slowly but surely over the next few years began to see a whole way of doing things that was different from what I was trained. These women, even though they were being transferred to the hospital, they were not being transferred for emergencies. They were being transferred because they were tired and they just wanted an epidural and maybe some Pitocin, and they would still deliver vaginally. And I'd have a lot of time to sit around and talk with the midwives in the doctor's lounge, and we'd hang out, and we would, and I began to see like these patients are actually more well educated than mine. There's a whole nother way of doing things. Why am I doing all these vaginal exams? Why am I inducing people? Why do I medicalize everything? And so about 10 years into my private practice, I started a collaborative practice with 2 midwives at another hospital. At Cedars-Sinai at that time did not allow midwives to have privileges. And so we started in another county, and we were there for 15 years, and we had really good results. The midwives did all the normal stuff. They did the pap smears, the well woman exams, they did the well OB checks, they did prenatal care, they did the normal deliveries, and I would do the surgeries, and I would do the colposcopies for abnormal pap smears and biopsies, and I would do the gynecologic surgery, and I would do the C-sections and the breech deliveries and the twin deliveries. And we had really great numbers. We had our C-section rate of about 7% over 15 years. And the other groups in the same hospital had C-section rates of between 25 and 40%. And the same population of women. So the only difference was the model of care. And I began to learn that there's a much better way to care for women in pregnancy, and it doesn't involve fear and anxiety all the time. And but we were never accepted in the hospital world, Christy. And eventually they decided they were not going to renew my privileges. And so I was faced with a legal fight or to leave and go to do home birthing. And I had some very wise advisors, including some local midwives. And I ended up, after 25 years of hospital-based birthing, I went to my first home birth. And it was beautiful and it was great. And I've never looked back. And I got bolder as time went by, and I started to say, listen, why can't breeches be born at home? Why can't vaginal birth after cesareans be born at home? Why can't diabetics be born at home? Why can't hypertensives be born at home? What's the deal? If they're stable, they're not going to suddenly deteriorate at home, where the point where you have to shovel them down the hall to the operating room. That happens in the hospital mainly because of how the hospital manages the woman in labor. All the interventions, the immobilization, the starvation, the interruptions, the epidural, which separates mother from her baby. Then the need for Pitocin because the epidural spaced out the contractions. And then the baby doesn't like it anymore because the baby's no longer in communication with its mother. And there's a beautiful cocktail that goes on between mother and baby from the moment it's conceived, a hormonal cocktail. And when you give a woman an epidural, she's now numb. She's no longer communicating with her baby. And the baby doesn't really know what's going on. And you see this deterioration in the fetal heart rate. And nobody really knows what it means, but they always intervene upon it. And often we'll do a C-section. And they'll get a baby that comes out screaming, and it's great. And they'll say, see, we saved your baby. But the truth is that your whole process caused the baby to be troubled in the first place. And if you would just left her alone, she probably would have done fine, as statistics do show. So I was forced out of the hospital, and it was the best thing that ever happened to me.
Yeah, I mean, it's crazy how these things happen like that. I mean, I forced myself out of the news industry. I mean, being a news anchor was my dream, and I'm so glad I got to do it. But when I saw what happened to the industry and how it all became propaganda, I basically forced myself out in order to feel good about what I'm doing. So I think that that's the camaraderie I feel with people like you that aren't afraid to take those risks and chances and follow a much higher calling. But as far as my experience, just for the context of carrying this story, I don't know what in the heck ever made me interested in water birth. I think I was like a fan of shows, documentary type shows on TV. And I was like, oh, that looks interesting. I remember seeing Ricky Lake and her water birth. I'm like, I'm going to look into that. And being that I'm a journalist researcher at heart, I dove into it and had 3 amazing water births when I was younger. and this has been a different ride being 41 now, having another baby. So before we dive into kind of the breech thing, which is another thing I've experienced this time, maybe talk about how the medical system treats you when you're older, because I mean, I had 3 all natural, beautiful births, and the first doctor I went to was like, "Okay, you're due on the 26th. When would you like your induction? How about the 19th?" I'm like, "Why do I need to be induced?" Like, why? Because of my age. So maybe speak on that before we dive into the breech topic.
I would love to speak on this topic. Okay. This gets back to, again, sort of medical indoctrination and brainwashing in residency and medical school, where doctors are fed information and that's all they learn. And when they come out, their intellectual curiosity is beaten out of them by the system in which they work in. And they never bother to dig deep or dive deep. They just follow the protocols or policies that are put forth by either their hospital medical staff or the American College of OBGYN. And no one ever stops to think for a second, why? Why are we doing that? Why are we telling women that when they're over 35, that they suddenly have this huge problem? At 34, they're fine, but at 35, they're not. Just even logically, it makes no sense. And actually, statistically, it makes no sense. There's no data to support what you're being told and all the fear that's being pushed about being advanced maternal age. That doesn't support that. I mean, this gets into the details between what's called relative risk and what's called actual risk. With relative risk is something where things will go up and you just compare them to other numbers. But actual risk is what is the actual risk. And a good example for that is if something happened in California last year one time, then the risk would be 1 in 40 million. And that's essentially zero. And say this year it happened 10 times. Well, they can then talk about relative risk and they say, oh my God, there's been a 10-fold increase in this problem. Yeah, but the actual risk is still 1 in 4 million, which is still zero. So it depends on how you want to skew your counseling to funnel people down a path you want them to take. And if all doctors think of birth as something to be fear and something to be controlled, then they're going to propagate this stuff. But there's really no significant difference between a woman who's 30, 32 or 27 or 38 or 41 when it comes to your labor that requires any interventions whatsoever. What our model says is that this is a normal function. Your body was able to conceive, Christy. It's able to grow a pregnancy. Suddenly it's not able to do anything else. That makes absolutely no sense. So we end up with a situation where if you leave things alone, then it will go right most of the time. And when it doesn't go right, it isn't something emergently that happens like in the hospital. It's something you can see coming. And when you have a well-trained midwife who's trained in normal birth, who's an expert in normal birth, they're very quick to recognize abnormal. And so it's very easy for them to say, hey, your labor isn't going well, or hey, your baby isn't growing well. And then maybe refer you for a consult. But the idea that you need to be medicalized the entire time because you have a higher risk of this or a higher risk of that, well, higher risk means nothing. It doesn't mean anything unless you know what the denominator is, as I said. So they'll use the term high risk, and you ask them, what is the actual risk? And they'll go, well, it's high. And then you'll say, well, how high? And they'll say, really high. And the actual truth is they don't know because they've never bothered to look and give honest, informed consent, because what might be high to you might not be high to your next door neighbor. And everybody has their own history and their own background. And that's the beauty of the care that is offered by midwives, is that it's individualized. And they have the time to spend an hour with you at every prenatal visit. And in an hour, you can accomplish a lot more preventative care and nurturing and stress reduction than you can in a 6 or 7 minute office visit with your OB, who has to see volume because of the system that they're stuck in, which is, low reimbursement rates, high overhead, high liability. So they have to, move them in and move them out. And they have to have lots and lots of patients, because that's how they even call them patients. In the midwifery model, we don't call you patients, we call you clients, because you're not sick until you are sick. And once you're sick, it's great to have a hospital. It's great to have a maternal fetal medicine specialist. It's great to have interventions that can help save you and your baby. But the idea that every single woman needs to be thinking about that her entire pregnancy means that, that means they're bathing their baby as it develops in fear-based hormones, adrenaline, cortisol, things that aren't really beneficial. You should be bathing your baby in endorphins and oxytocin. You should be laughing. You should be smiling. You shouldn't watch horror movies when you're pregnant. You should watch comedies and love stories. This is the kind of, it's just simple things that stop being so worried about something that is so normal.
Yeah, and I mean that is the thing. I mean, so much of, in my experience of having babies naturally, is a mental preparation and visualization of things. And so when thoughts are put into your head that something could go wrong, it kind of sets you all off balance in like planning your birth. But there's a couple things that even I didn't really necessarily know were options. Being that I'm older, you tend to hear that you have a higher chance of having multiples. So I was like, would I still be able to have a vaginal birth if I have twins? And I actually didn't even know, because you never hear about that. But that's something that you specialize in, as well as breech. Now, the propaganda puppets are always pumping out in lockstep one narrative. But did you know that the one narrative starts before you even come into this world? You're primed and ready. The way that you came into this world might have been based on an illogical, only one narrative construct. So we're bringing the counter narrative to birth, how you can be brought into this world. And we're doing that with Dr. Stu. Welcome back in, Dr. Stu. Before the break, we were just getting ready to talk about your passion, which is breech natural birth and twin vaginal birth. And so I was talking about how I myself wasn't even sure if that was a thing that you could do. If you search and Google things, like, it will be like, it's recommended that you get a cesarean. Never had breech babies before. First time I ever had a breech baby is this pregnancy, and everything I can find on the internet was saying doctor will recommend a C-section. Even my midwife was saying you need to wrap your mind around possibly at least setting a C-section appointment, because I'm not trained in breech. I'm going to have to find somebody that is. So, I was totally blindsided with this, and really encouraged when I found your podcast. So tell me how that became a passion.
Well, I was lucky. As I said earlier, I was trained in an era where breech and twins were considered normal. It was the early 80s. And so it was just a skill that any obstetrician should have. And ultimately, right now, if you look at what obstetricians do and all the subspecialties, It's the only thing that makes the specialty of obstetrics unique, because pretty much everything else an obstetrician does, from a pap smear to a C-section and everything in between, can be done by a subspecialist. So the generalist OB who doesn't do breaches and twins or maybe put on forceps doesn't really have the skills to be called an obstetrician. And yet the leading organization for obstetricians, the American College of OBGYN, while they have a tepid support for breech and twin vaginal delivery in their guidelines, it has no teeth. What's really interesting about something called confirmation bias is that when the American College of OBGYN puts out a guideline that supports the way that doctors want to practice, it's accepted immediately. But when they put out a guideline that says there's alternatives or something that isn't the way the doctors want to practice, that it's ignored. It's just classic stuff. We see it in real life as well. I mean, I won't get into politics because that's your specialty, but it's just a funny thing. So anyway, I was trained to do breech delivery, and then there was some papers coming out in the late 80s, early 90s about C-section for breech, and there were papers coming out that supported vaginal delivery for breech. And so it just almost seemed like the community was ripe for a paper that would be definitive. So there was a paper that came out of Canada called the Turn Breech Trial in 2000, which said definitively that C-section is safer for breech. And so immediately around the world, residency programs and hospitals stopped doing breech delivery. They took a look at that paper critically, and quite frankly, I have no idea how that paper got through peer review, other than it was probably because they wanted it to get through peer review. Because within 2 years, pretty much everything about that paper was found to be flawed. And they came out with a retraction of the paper, but it didn't matter. The damage had been done, and no longer in any residency program and in any hospital or any doctor who even knew how to do breeches, the pressures were so against them in the community that they stopped doing breech delivery and they started sectioning all breeches. But the numbers, if you look at it, don't make any sense for that. And pretty much every paper, Christy, since that time that's come out, many of them much bigger studies than the term breech trial, have shown that there's almost no difference between vaginal delivery for term breech and vaginal delivery and cesarean delivery for term breech. And clearly, there's almost no difference between vaginal delivery for term breech and vaginal delivery for head down babies. There's almost no difference whatsoever.
So as you were saying, the breech birth, they stoke all this fear, but you said even the difference between not only cesarean breech birth and vaginal breech birth, but just head down and breech birth is virtually the same. I mean, you would never know that trying to research this online.
No, and most doctors don't know it for the same reason that we talked about before. They never bothered to even check it out because they've been told that C-section for breech is what they should do. And why would they do any differently? There's no incentive for a doctor to buck the system. When you do a C-section, it's scheduled at 7:30 in the morning. You're out by 8:20. You know exactly how long it's going to take. You know exactly when it's going to be done. You don't get paid much more for that, but you get your day free. Whereas if you allow a woman to have a breech delivery, the hospital will probably mandate that you're in the hospital the entire time she's in labor, and you don't get paid more for that. And so there's very little incentive for a doctor to offer it other than to give the patients the satisfaction of supporting what they want, meeting their desires and their needs. So we end up with a situation where if you have a C-section for breech, and the best numbers for this comes from the Royal College of Obstetrics and Gynecology Green Top Guidelines from 2017. I don't want to get too deep in the weeds here, but they say that the risk of having a neonatal death is about 1 in 2,000. And the risk of having a neonatal death from a vaginal breech birth is about 1 in 500. So that's a 4-fold increase. But remember, we talked about how relative risk can be used to skew your counseling. So even though it's a 4-fold increase, what is the actual risk? And the actual risk is a 99.8% chance of it not happening with a vaginal breech, and a 99.95% chance of it not happening with a cesarean for breech. And to throw some contrast in there, for a head down baby, the risk is 1 in 1,000, or 99.9 chance it's not going to happen. So the difference between a breech and a head down baby is 99.8 versus 99.9. If you told that to most women, how many women would choose to have a C-section for a 1 in 1,000 difference?
Yeah, but the ways they instill fear in you is very effective. They say, "Oh, well, with the breach, the head can get stuck, or the cord placement could be deadly." Can you address those things that they throw at you?
Well, that's not true. It's just not true. Is it more common? Yes. Is it common? No. And again,
Mm.
it's the skewing of consent to get you to do what they don't want you to do because they fear breach. And so they project their anxieties onto the women that they care for. And this is an ethical dilemma. You're not supposed to do that. You know, you can go home and you can complain to your spouse about how nervous you are doing something, but you shouldn't be dumping that on the patient. You should be honest with the patient. And if you don't like doing it, just say, listen, I'm not comfortable with that, but I know somebody across town who does breaches. So maybe you should go have a consult with her and see what she says and then come back and we'll talk about it. That would be a very ethical thing to do. But to tell them, oh, the head will get stuck or the cord will fall out, that's unethical because it's not that common. And if you are a skilled breech practitioner, you know how to deal with those sorts of things. This is the kind of thing that we teach when we go around the country and the world. Actually, I'll be in Ireland next month and then London in November teaching this, which is exciting for me to go to other countries and hear their problems because they got worse problems than we do, I think.
That's hard to
So that's the
believe.
story.
Doing this show, it's hard to believe that there's bigger problems elsewhere anymore. But
Oh, there's
I,
medical tyranny is universal. I mean, some countries don't even. It's illegal to birth at home. It's illegal to have a midwife in some European countries and in some Asian countries. So
wow.
yeah, it's an amazing thing that again it's sort of it gets to the idea of wanting to control every aspect of your life, and we've seen that in what's going on in the political world that we
Yeah.
have right now. But it's been going on it's been going on in the medical world for hundreds of years. You know, men pushed midwives were the keepers of women's sacred trust and birthing for millennia, and then they were burned at the stake. Literally, they were called
Wow.
witches, and they were burned at the stake, and then they were pushed out. And then you had the South, where you had the granny midwives, the black midwives, who took care of those people for centuries. And then suddenly they were vilified by an ad campaign by the American Medical Association. Um, it's corporate tyranny, and it's been very effective, as you said, because if you say breach to the average consumer, the only thing they know about it is that it's dangerous, and that's absolutely not true. Breech birth succeeds or not for the same reason that head down babies do if you're properly selected and you have a skilled practitioner. Problem is finding somebody willing and skilled these days. But women who have a breech baby, especially if it's your first baby, if they have to cross state lines, if they have to spend money out of pocket, you need to do that. Because if you have a C-section for that first baby, whether it's twins or breech, and say you want a second pregnancy, then all you've done for that little bit that you might have saved risk to that first baby is now, because you have a scarred uterus from the C-section, is you pass it on to every single baby that you have after that. That baby is now at more risk, and you as a mother are now at more risk for a placental implantation problem called a creta or a ruptured uterus with that sort of thing. So you save nothing by having a woman have a C-section for breech if she wants a second child.
Yeah, and I mean, that's the thing too that we're seeing over and over again exposed through the pandemic is this whole concept of informed consent. Women are not told that. They're told C-section is so common and quick and then, accepted for if you're older or have gestational diabetes or you have a breech baby. It's just accepted. You're not told, well, here's the true, give and take of it. But that being said, you know, you've convinced me and I think opened the eyes of a lot of people about how safe breach can be, but you still need to be able to find somebody willing to do it. And what can we do to get more people trained and able to do it? Because right now I'm reading stories about whole birthing centers and hospitals being shut down. And I mean, we have an epidemic of just places to give birth right now on top of everything else.
We have increasing maternity care deserts. That's absolutely true. We have hospitals that are banning simple things like vaginal birth after cesarean or breech delivery. Hospitals that are closing their doors to obstetrical care. Women have to drive hundreds of miles to do that. That's because of the model by which we live in. It's the medical, legal, economically driven model. It has nothing to do with healthcare. People have to understand that healthcare is not about care. It's a business. And if, again, like I said, if they were doing good work and they're having really good numbers, you could say, okay, it's a trade-off. But I can tell you from experience that the newborn intensive care unit in most hospitals that have one is often filled with babies who are 7 or 8 pounds that came into the hospital inside their mothers in perfect condition. And they end up in the NICU. And no one seems to look at the hospital model and say, geez, what are we doing wrong? Why are these babies ending up in the NICU? You know, the one bad outcome that comes from a home birth, that gets publicized over, all over the place. But when babies are mistreated, when babies are, sort of assaulted, they have injuries that are iatrogenic, which means, caused by the medical system. That's hush hush. They circle the wagons. No one talks about that sort of thing, and it just disappears from the news if it ever makes the news at all. So the point being is that if a woman has breech or twins, they need to make it a priority, make it a high value to go and seek out somebody who can help them. And that may mean crossing state lines. That may mean driving 200 miles. That may mean paying out of pocket. I encourage every family that's listening to start a health savings account, and to start a health savings account for your 1-year-old baby. Put $20 a month into a savings account and start it. By the time she's 30, there'll be thousands of dollars in there, and it will give her the freedom to pick the birth or whatever health decision she wants for herself, because we're only going to get more tyrannical. As funding gets less, and when something's in its death throes, as I believe the medical industrial complex is, they tend to push back harder. More and more people figured it out during the pandemic that your best interest isn't what's at heart here, and that's happening in medicine too. We're seeing more and more home births. We need more midwives, and we need more people to understand that birth is not a disease.
Exactly. And moving forward, some people didn't understand why I was so distraught about this whole situation of like, oh no, I'm so far along and I need to figure out a second game plan to stay out of the hospital. There's people that don't understand why I'm so afraid of going to the hospital. But after all the interviews I've done of what they did to people during the pandemic, I'm like, I want to stay as far away from the hospital as possible. And part of that is because I've had to experience the judgment and the shame and the like, sign this because you're refusing a vaccine, not sign this to allow us to put something in your child. So it terrifies me. I want to stay as far away from the hospital and traditional medicine as possible. That being said, I know that you were on with one of our recent guests, Brian Hooker, about the vaccine schedule and, how they immediately want to put Hep B in your infant as soon as they're born. Curious your thoughts. Have you always felt kind of hesitant about vaccines, or is that something newer that you've discovered because you're a critical thinker?
When I came out of residency, I was very medicalized, and I thought babies should have vitamin K shots. They should have Hep B shots. They should have erythromycin put in their eyes. They should do that. I don't think that in the last 20 years, I've had one of my clients want that. But that, I'm seeing a skewed population. We could really go off on a tangent with what the American College of Obstetrics and Gynecology has done with their support of giving a healthy pregnant woman, encouraging doctors to skew their counseling to get them to take at least 4 vaccines while they're pregnant. 4 vaccines, by the way, that have never been tested against a randomized placebo-controlled trial, and certainly never been tested in pregnant women, and certainly never been tested in giving 4 at one time or 3 at one time. You know, I think it's the 6-month baby visit that a baby gets, I think, 3 or 4 shots, gets 3 shots, I think, with 8 different vaccines at the same time. Not one of those vaccines has ever been tested for safety against a placebo, which would be like normal saline. And never have they been tested giving them at the same time. And yet, the American Academy of Pediatrics, the American College of OBGYN, the American Medical Association, the CDC, they're all pushing this on people. That should be the scariest reason, or not the scariest, that should be scary enough to give you a reason to never trust any doctor who's pushing that upon you, because none of it makes sense. And to give these things, especially to young kids who are their immune systems are perfect, they're working. We've seen a rise in chronic illness in children. I mean, Paul Thomas, I don't know if you've ever had him on, but he's a great guest, speaks about it. And so does Brian and RFK Jr. in their book, Vaxxed Unvaxxed, about the idea that in over 19 different categories of wellness, the unvaccinated kids were healthier than the vaccinated kids in all 19 of them. And we've seen a chronic illness rate rise from single digits to over 50% of children now have at least some chronic illness, running anyway from like eczema to autism and everything pretty much in between, asthma and other things like that. And it all starts when they're born. There is absolutely no reason to give a newborn baby a hepatitis vaccine unless the parents have active hepatitis. And even then, if you want to give gamma globulin, probably not. The vaccine isn't going to work that fast anyway. So there's absolutely no reason to do it. And yet every hospital, tries to get you to do it. Part of it is because they make money when you do it. There's no money, Christy, in doing nothing. And that's a big problem for the hospitals, because the hospitals only make money when they're doing stuff.
Yeah, it's really, really sad that we have to be this jaded to realize that so many of these medical decisions are money related or just plain old conflict of interest related because of all of the connections. It's just awful. But I just saw this article from Vigilante News about a former major city police detective revealing that 50% of SIDS cases happened within 40 hours of the post-vaccine. And this person, of course, wanted to remain anonymous in the article, but she did independently verify her full name and employment at this police department. But she has personally handled 250 SID cases, and 50% of them happened within 40 hours after a vaccine was given, and about 70% of the cases happened within 1 week. Do you have any thoughts on that correlation made? This isn't the first time I've heard it.
Oh, I do. And also, we had a new disease that developed during the first year of the COVID vaccine, which is called SADS, which was sudden adult death syndrome, which never occurred before whatsoever. You've seen it all over. Died suddenly. If you're on your Instagram feed, you're going to see these things posted all over the place. The SIDS thing is really an important thing. I again, there's always plausible deniability because correlation doesn't necessarily mean causation, but it certainly is suspicious. And one of the good pieces of evidence that came out recently was there was a decrease in SIDS deaths during the lockdown. So think about that for a second. Why would there be a decrease of SIDS deaths during the lockdown? So the lockdown occurred before the vaccine came out. So we're talking 2020. So what's the one thing that happened during the lockdown is that parents didn't take their kids to the pediatrician. Mm-hmm. And kids didn't get their scheduled vaccines. Mm-hmm. And then they saw a drop in the levels. Is that proof? No. But you have to be mighty foolish to not consider that that's a possibility. Again, in a product that's never been tested for safety. Did we talk about those already? The word safe and effective? I don't think we did. But the two words safe and effective, it's kind of like the movie Princess Bride, where Fenzini keeps saying the word inconceivable. And Inigo Montoya says to him, I don't think that word means what you think it means. And the same thing goes on with safe and effective. Um, Safe and effective is a lie. Any doctor that tells you a vaccine is safe and effective is lying to you, because they no longer can be obtusely stupid. There's enough evidence out there to tell you if they wanted to look. And if you're a physician and you're not looking at the evidence, then you're lying. And they need to be called out. The time to be sweet to people and give them the benefit of the doubt is over. The medical model has failed us. It's failed us badly. That's why you see this huge rise in natural medicines and people with nutrition and all these supplements on commercials at late night TV, and drinking your breakfast, morning complete or athletic greens or whatever, and you're trying to find and restore a healthy lifestyle. The best thing you can do when you're pregnant or even when you're not is laugh, get outside, get some sunlight, get some exercise, make love, and read a good novel, and don't get caught up in the fear and anxieties that our society is. The problem is for those of us, like, it's your business. You have to read this stuff. I really admire you for the fact that you said you left the network news. I mean, like I said, it was the best thing that ever happened to me. I didn't really want to do it, but it freed me to be somebody where I can speak freely, because I don't have a master. I don't have a boss. I don't have the medical board. Yeah, the medical board can say whatever they want, but at this point in my career, I really don't care that much anymore, because I can speak freely whether I have whether I'm licensed in a state or not licensed in a state. They can't shut me up. Well, they can, but they can. There are certain things they can do, like cancel you and stuff. But
I was going to ask you about that, actually, because you're in California still, right?
No, I've moved to southern Utah. I left California last November, and I'm living in a small town in southern Utah. It's absolutely gorgeous here. I ride my bike to the grocery store. My town has 2 stoplights in it. My whole town. So I'm very happy here. I'm still licensed in California. I'm also licensed in Utah. But I'm not clinically practicing on a regular basis anymore. I still attend some bursts periodically. But I don't, at this point, I'm like, I don't care, because it's so easy to speak the truth. I don't understand. I mean, Peter McCullough was speaking in Europe last week, and he said something that was really poignant. He said that how is it that thousands and thousands of doctors could have injected this medicine into their patients and their family members, and now be jumping on the bandwagon for the new booster shot. And the reason is because the idea of facing the idea that you gave this toxin to your family members and your patients is too hard to think of. And so this thing of like mass formation psychosis sets in, and you feel better off with the collective than you do feel for the individual person. And so you sacrifice yourself, because the idea of coming clean is hard. It's hard for people to admit they made a mistake. I freely admit that the first 5 or 10 years of practice, I did some really stupid stuff. I did C-sections on people who didn't need C-sections. I induced people who didn't need to be induced. I made people lay flat on their back. I pushed epidurals because that's what I thought was correct. It's time for those people to wake up. It's never too late to admit that you're doing it wrong and make a change. It's never too late.
I love that. And I think that's a great way to end. This went by so fast. There's a million other topics we could have delved into even further, but hopefully we can have you back on the show. I really enjoyed having you on, and I hope my viewers did as well. Thank you so much, Dr. Stu.
Christy, thank you for giving me the opportunity to speak to your audience. I really appreciate it. And I hope that they take a deep dive into all their healthcare choices.
Yes, they're smart enough to do that. I believe it.